and now we'll move on to the next session, which is presidential oration. And for that, I would like to call upon Dr. Mahendranath and Dr. Aman Sharma on the stage. Dr. Mahendranath, he's a senior consultant rheumatologist at Bengaluru, and Dr. Aman Sharma is a professor at Department of Clinical Immunology and Rheumatology at PGI Chandigarh.
Aman Sharma, my co-chairperson, my esteemed colleagues. One of the most important event of the annual Congress is the presidential oration. And this year, Dr. B.G. Dharmanand, the current president of the Indian Rheumatology Association, is going to give you the oration. We don't know what he's going to talk. He has never told us. So before that, there's a ceremonial thing to give a honorary medal and a certificate for the president.
Good morning, friends. Thank you, chairpersons. The topic I have chosen is treatment of autoimmune rheumatic disease. We should think beyond immunosuppression. I am proud to be here amongst you all today. I consider sometimes as we are now victim of our own success. We have made tremendous amount of progress, and we have effective treatment for most of the rheumatic diseases, which we had no treatment until a couple of decades ago. Sometimes this can lead to complacency and accept the current treatment as the standard, and sometimes we stop thinking beyond it. So thinking beyond immunosuppression, oncology treatment is always considered as the prototype of immunosuppressive treatment. They have started thinking differently, radically differently, and they have taken up checkpoint inhibition, tapping our natural ability to attack the cancer cells by activating the immune system, thereby creating a new autoimmune disease for us, new headache for us, but good results for the oncology patients. And they have also embraced CAR-T-based cell therapy, and it is easier in oncology because the targets are very well known. And autoimmune diseases are much more tricky, and antigens are mostly unknown. And also, oncologists and nephrologists get away with the perils of immunosuppression because cancer and end-stage renal disease are considered as very severe diseases by everybody. And patients accept collateral damage, and their doctors accept it, and their general practitioners, family, everybody accepts it. But contrast to we have failed to convince our patients about the gravity and seriousness of our diseases. And when our patients develop even a minor side effects, we are blamed many a times. So standard of care for autoimmune rheumatic disease has been steroid, immunosuppressives, both intense for induction and maintenance, DMRDs, targeted synthetic DMRDs, and biological DMRDs. I'm not going to talk about this. And we have a smart battle going on, whether we are using immunosuppressive medications or immunomodulation. And Professor Malavia will be unhappy with me when I use immunosuppression. He always stood up and said, we are not using immunosuppressives, we are immunomodulating. But there seemed to be a confusion even amongst the rheumatologists and august bodies of rheumatology. You all are in the recent one of the COVID guidance quoted that immunosuppressive treatment, including synthetic DMRDs and biological DMRDs. So they have clubbed all the drugs we use as an immunosuppressant, whereas American College of Rheumatology seem to discriminate. They used conventional immunosuppressive medications as immunosuppressants and as biological DMRDs and DMRDs. So still, we don't know whether we are really immunosuppressing or immunomodulating. There are only few immunomodulatory drugs available to us: hydroxychloroquine, colchicine, and sulfasalazine. All other drugs are immunosuppressive to a variable extent. And in most studies, the incidence of serious infection is between 3 to 6 per patient, 100 patient years. And infectious complications are up to 20% in many studies. And they are trial data. They don't reflect the real world data, because we also treat patients with multiple comorbidities, particularly diabetes and other age-related issues. And we should not also underestimate the morbidity of even minor infections. The minor infections, every time the patient gets a UTI, they lose time off work, they lose money because most of our patients are self-paid. And every infection probably will lead to little bit of loss of nephrons because of hypovolemia and related issues, little bit of loss of muscles, and sometimes loss of neurons. So it is, though it's minor, but still carries morbidity. This is a huge list of complications of immunosuppressive therapy. We know that it is not very common, but it is a huge list: infections, various idiosyncratic reactions, and malignancy risks, steroid-related issues. And immunosuppressive therapy also masks signs of infection and delay the diagnosis, thereby increase the morbidity. And I'm sure you all will agree with me that apart from doing diagnostic work in our outpatient department, most of our time is spent on managing the side effects of the drugs. How many of would you agree with that? And most of the time I do that in my practice, is managing the side effects of the drugs. And this is our study led by Dr. Vinita Shobha and Chandrasekhar. It shows that up to 30–40% of our patients have multiple comorbidities. And our infection study, in a 6 months period, we had almost 14% of patients developing at least a minor infection. And the infection risk is more common with multiple DMRDs, triple DMRDs, biologicals, and lupus and steroids. And I would encourage you to read this nice article by Dr. Mendel, Hiding in Clear Sight: Complications of Immunosuppressive Therapies. Because we have accepted this as the norm, we have accepted this as the standard of care, we conveniently sometimes overlook the problems, morbidities associated with the treatment, and we accept it as a part and parcel of the game. And even the studies, BSR registry data, we convince ourselves that the biologicals, if I read that, no difference in the rates of serious infection between patients receiving TNF antagonists and patients receiving traditional DMRDs. So we satisfy ourselves that we are not doing greater harm by using biologicals. But if you look at the actual graph, even the conventional DMRDs, the infection rate is between 6 to 8% patient year. So it is not uncommon. So we are just telling that the other drugs, the newer drugs, are as good or as bad as the conventional drugs. And when it comes to approach to autoimmune disease, my friend Chandrasekhara is our president-elect. He has written a very nice article. I would encourage all the youngsters to read this. Sometimes we borrow idea from oncology in the form of remission, induction, and maintenance, infectious diseases, metabolic diseases, and transplant immunology, and try to implement that strategy into autoimmune diseases. And he argues that autoimmune disease is much more tricky, and we need to evolve a new strategy. So we have done very well. Can we do better? Current drugs are effective, but they are not uniformly effective. Predicting response and choosing a right drug is still a work in progress. We don't have predictive markers. So trial and run, hit and run method, and with some intelligent guess is the way we choose the drug. Secondary failure is not uncommon. Retention rates are low. We are trying to get a new molecule because there is always an unmet need. 15 years ago, we always talking about unmet need in the treatment of rheumatoid arthritis. After approval of more than 10 new drugs in the last decade or so, we still talk about unmet needs. So when we tackle immune system in one direction, it starts probably, takes a detour and starts, immune deviation happens, and we try to overcome it, like very similar to how we are dealing with antibiotic resistance. We are trying to develop a new drug rather than regulate whether the patients really require an antibiotic. So we need true immunomodulatory drugs, both in drug form and non-pharmacological forms. So this is okay. Sorry, I don't know how to do this. So there are few non-modifiable risk factors: genes, gender, age, hormones. I don't think we can really do anything about it. But look at the other parameters which influence the immune function: nutrition, obesity, alcohol, exercise, stress, infection. Sometimes we don't have a control, but we can try to modify it. So there are quite a few modifiable factors where we can try to intervene. So we all blame the alternative medical practitioners. Still, we don't know how and why people choose alternative medicine. It is both behavioral, social, availability of healthcare. All these lead to patients choosing alternate care. And I have to tell that we and our patients sometimes have different perceptions because we are developed from two different schools of thought. Modern medicine is one of the many choices in front of our patients. We think that we are the only choice, but from the patient point of view, we are one of the choice. They don't know whether allopathy is better or homeopathy is better. They don't have no idea. And sometimes we also become intellectually arrogant, and we think that what we are doing is the right thing. All others are quacks. That is the attitude we have. But people don't share this view all the time. And even our own colleagues may not share the same enthusiasm as we have for our specialty. We have the scary reputation of the specialty using very serious, dangerous, scary drugs. And current research is also, probably in our days when we started, there are lots of articles about etiology, intestinal permeability, the stress on a Kelly book was more pages were dedicated to why disease happens. Now that is taking a back seat. We will fix it after it comes up. That attitude is taking the driver's seat. And we also don't know why this patient is having a secondary failure. If they are not going to address the original event which made them get an autoimmune disease, unless that is addressed, if the person continues to smoke, his DMRDs are not going to be that effective. If he is continuing to eat crappy Western diet, I don't think his gut bacteria is going to get better. So we try to overlook all these things and try to invent a new drug to tackle the relapse of the disease. And industry is driving a research. I'm not against it, but they only seem to be driving the agenda of the science at this moment. And our training is also truly medicine-oriented training. So we hardly have any knowledge and training on exercise. We are supposed to be rheumatologists, supposed to know the musculoskeletal system. How many of us had a course or a small module on exercise physiology? None of us. And how many of us are taught a module of nutrition and autoimmune diseases? If you look at the literature, there are thousands and thousands of articles written on this chapter. So we need to teach tolerance. The conventional treatment is managing the symptoms. We aggressively target the whole immune system. Now we are intelligently targeting specific targets which we have understood from basic science, biologicals, targeted synthetic DMRDs. I think we should focus on downregulation of only the specific immune reaction that has gone wrong. Some strategies have been adapted, though not successfully, tolerating antigens and peptides. But problem in rheumatology and autoimmune diseases, our targets are not clearly known. And they are trying to manipulate IL-2 pathway to nudge IL-2 to favor Treg pathway. And we are also trying to use now cells as a weapon. This is a novel strategy. Antigen-specific dendritic cells to re-establish tolerance is a strategy. It is being now tried in animal models. Mesenchymal stromal cells can have both immunomodulatory and regenerative role. Treg cells and Treg cells are again not stable. Depending upon the environment, it can become either effector or T regulatory cells. So the research is going on how to stabilize Treg cell to remain Treg cells and do its job. And CAR T technology may be useful, and CAR T reg cells have been developed, and B reg cells are used. And CAR T therapy has been successfully used in cancer, and preliminary studies in lupus has been encouraging, but that is not the immunomodulation I was talking about, that is immunoablative. We know that B cell is a potential target, and they are able to target with CAR T. That is immunoablative. It's not a immunomodulatory. I am talking about CAR T regulatory cells, producing regulatory cells against a potential antigen. Another target can be metabolic pathway, and there is already some preliminary data about targeting using metformin for lupus. There is encouraging data in the preliminary studies. There are many pathways in the metabolism. Our T cells, when they are immune activated, have to use energy, and mTOR pathway, AMPK pathways have been the targets along with multiple other pathways. I really don't understand many of the biochemical pathways, but there are targets which are there. Some of the drugs like dimethyl fumarate, without us understanding its role in the past, has become a good drug for psoriasis and multiple sclerosis. So metabolic pathway can be a potential non-immunosuppressive target. And another strategy is to protect the organs against autoimmune diseases. We target the immune system, but we can also target the organs which the immune system acts upon by using topical strategies. Topical JAK can be useful in probably atopic dermatitis and some of the other autoimmune skin diseases. And the interest has been on using topical microbiome infused moisturizers for cutaneous autoimmune diseases. We know that cutaneous autoimmune diseases have altered cutaneous microbiome. And using these sanitizers, which is there everywhere, I think alter our skin microbiome and can lead to some contact dermatitis. And another strategy is using zonulin antagonist peptides, larosotidine, which is tried in celiac disease, though company has stopped the trial because they required much larger population, and probably the company could not afford it. But this is a potential strategy because intestinal permeability is one of the etiological cause for most of the autoimmune diseases. And fasting mimicking diets have been useful in protecting oligodendrocytes in MS animal models. Metformin again had shown a similar response in multiple sclerosis studies. It protects oligodendrocytes. And DAPA, I have not still managed to pronounce it correctly, I'll call it as DAPA, and is a potentially very useful drug in lupus nephritis. Another target can be microbiome. Microbiome may be the link between nutrition, diet, and autoimmune disease. Probably I'll add obesity here as well. Short chain fatty acids are increasingly recognized as an important metabolite in intestinal immune homeostasis. It improves the intestinal permeability, induces Treg cells, promote long-term survival of CD8 T cells as memory cells. And proof of the concept has come in some autoimmune diseases, particularly IBD, in the form of fecal transplantation. It's a microbiome transplant. It has shown good effect on obesity and IBD. And I think this future is in some form of this therapy. And fasting also may partly enforce the effect through microbiome settings. Fasting is an effective tool for many autoimmune diseases. It might be acting through microbiome resetting. And microbiome-derived small molecules may play a part in the crosstalk between microbiome and human host. there may be potential target for drug development there. So if they know what is the microbial product, they may be able to produce and use it as a drug form. It's always better to use the whole, but sometimes it is convenient to use the drug form. And this is one of the latest concepts of autoimmune disease. So gut dysbiosis plays a dominant role apart from epigenetic changes, DNA methylation, etc., due to various pollutants, infections, etc., apart from genetic predisposition, can lead to autoimmune aberrant response, and ultimately, if it is sustained over time, can lead to autoimmune disease. Again, high fat, low fiber diet can cause gut dysbiosis that can lead to increased inflammasome activation and NFK kappa beta inhibition, and also change the gene transcription. All leads to immune dysregulation, increased inflammation, and can lead to metabolic diseases and autoimmune diseases. So these are all few dietary strategies which are tried in various studies: fasting mimicking diets, vegan diet, vegetarian lacto-vegetarian diet, gluten-free diet is very popular, is a fad now. Mediterranean diet has been well studied. Anti-inflammatory diet, which is the antithesis of classical pro-inflammatory diet. The typical Western diet is considered pro-inflammatory, and supplements like fish oil and vitamin D have been studied, and fish oil has been found to be useful, but the amount we have to use to have a meaningful effect is a very large amount, 3,000 to 6,000 milligram of EPA DHA. That would amount to eating 15 to 20 tablets of your standard fish oil pills which are available in the market. And some of the nutraceuticals like glucosamine, chondroitin, SAMI, ashwagandha, boswellia, turmeric have been used. They have a in vivo data on efficacy on the immune system, and it may have an adjunct role. This is an article, a diagram taken from Yehuda Schoenfeld's article. Coffee is supposed to promote rheumatoid factor positivity. Salt is pro-inflammatory. Omega-3 fatty acids, resveratrol, chocolate, dark chocolate, and curcumin are anti-inflammatory. Sugar is pro-inflammatory. So is there any evidence that diet matters? Inverse relationship between omega-3 intake and rheumatoid arthritis risk has been documented in multiple populations. There is a direct relation between red meat with inflammatory polyarthritis, but these studies have not been very consistent. Coffee, I have already told you. Tea and green tea seem to be protective. Alcohol seems to be surprisingly protective if it is done in moderation, so we'll enjoy our wine today. And vitamin D, and common sense is vitamin D seem to play a role in immune homeostasis. Having adequate vitamin D seem to favor Treg cell direction. And antioxidant index of the food seem to correlate with the RA risk. It is not antioxidant pills, the antioxidant index of the diet. So whole is better than part. And weight loss is another anti-inflammatory strategy. Obesity is a pro-inflammatory state, and if our patients manage to lose 10 to 15 kg weight, it may be anti-inflammatory. It may help them to reduce the inflammatory load. That might help them to reduce the DMRDs. And there could be a case for vegetarianism and vegan. And non-vegetarian food, meat, seem to have more shared epitopes with the many of the diseases which we deal with. And vegetarian diets seem to be better. And fasting, we know that fasting is useful to reduce the antigen load. So fasting induced hypoleptinemia seem to have a role in increasing the function of T regulatory cells. So ultimately we have to tap the T regulatory pathway and take the immune system away from the effector pathway. So I think it is attributed to Hippocrates. Every disease starts from the gut, and our Ayurveda also is very obsessed with gut, and there might be something there. We think that our father and grandfathers are, sometimes they don't know anything. There must be some wisdom in the ancient science, because the gut is the largest immune system, and it is the the commonest interface between self and non-self apart from our skin. And increased intestinal permeability is common in almost all autoimmune disease where it was studied. And by decreasing the antigen load, that is by fasting, I think we are eating too much too often, and that can put a load on the immune system. And we are exposing the immune system to not only to food and food-like particles, man-made food, like all our processed food. And fasting has shown to reduce the symptoms of rheumatoid arthritis, decreases lymphocytes. It's lymphocytopenic. When you fast, WBCs come down. And I've done that myself. When I did 5 days fasting, my lymphocytes came down to, from 40% came down to 20%. And when we refeed sensibly after fasting, the stem cells gets regenerated, and it also alters microbiome. And there is a strategy promoted by one of the scientists called Lango. He tried to do something called fasting mimicking diet, restricting the calorie to 800 calories, hoodwinking the body to think that it is fasting, whilst we still have the satisfaction of eating something. And that deviates the immune system towards the T regulatory cells. Less autoimmune cells or T cells comes down. And on refeeding, when the lymphocytes repopulate, they have less autoimmune phenotype. So this is an interesting strategy. Have been tried in multiple sclerosis. Early clinical trials have been supportive. And one of the ways fasting improves the health is to delay aging and immune aging. And by delaying aging, we reduce the incidence of diseases associated with aging. And it suppresses autoimmune cells. Refeeding helps to repair the stem cells. And we have quite a bit of studies. Fasting 1 year followed by vegetarian diet is a positive trial. Fasting followed by lacto-vegetarian diet has been a failed trial. So we have reasonable convincing evidence now to say that diets play a role. How to manipulate, still we have to learn. Another important area we can work on immune system is vagal stimulation. We have data on invasive vagus nerve stimulation and the rheumatoid arthritis. There are published studies. And there is also preliminary studies on non-invasive vagal stimulation for rheumatoid arthritis. A proof of concept study has been positive. And there is a reflex, cholinergic anti-inflammatory reflex. When there is a increased cytokines in the body, parasympathetic nervous system is activated, which is generally immunosuppressive. And there are many ways to activate the vagus through external methods. Even yoga, breathing, exercise may also contribute. One interesting study I saw during this preparation of this paper is grounding. They have used electrodes and ultimately they grounded like what we do for our home. That itself seemed to have helped the ulcer healing. So this is interesting. And yoga, Humira Badshah had published article about yoga, and she has shown benefit, positive benefit on yoga in rheumatoid arthritis. There are many studies, variable results. Quality of studies is a problem, but general trend is towards benefit. This Green Journal review on yoga and rheumatic disease shows weak evidence towards its efficacy in rheumatoid arthritis. But intuitively, yoga is suited for autoimmune rheumatic disease because yoga poses are good exercises. They improve balance, improves the range of movements of the joints, grip strength. Breathing exercises and meditation part of yoga improve the parasympathetic tone, potentially can have favorable effect on the immune inflammation. And our own Uma Kumar has published quite a few articles, and Negi's group have published good articles on the positive effect of yoga on rheumatoid arthritis. And mind-body medicine, one of the Dr. Uma Kumar's paper have demonstrated significant reduction of inflammatory cytokines, increase in brain-derived neurotropic factors, which probably will improve the fatigue and the brain function and brain fog. And it has been also found to be useful in fibromyalgia aspect of autoimmune rheumatic diseases. So there is moderate evidence that mind-body medicine can be a useful adjunct. Acupuncture is again is widely used, and the studies have been inconsistent, but it is a useful adjunct for pain management in osteoarthritis and non-inflammatory rheumatic diseases, and difficult to do a sham and a placebo-controlled study with acupuncture. That is why they are not able to get a really good positive response. So how do I integrate alternative strategies in my practice? Exercise, probably we'll have a lip service to exercise, but I think we have to give them a prescription of exercise. And exercise is immunomodulatory, and we all know that people who do regular exercises get less COVID and less severe COVID, but very severe exercise like running for a marathon can be immunosuppressive, makes you immunosuppressive transiently. And exercises activates a lot of epigenetic factors which favor anti-inflammation. Dietary intervention can be for everybody, avoiding pro-inflammatory food. Acupuncture is a pain-modifying drug. Yoga potentially for everybody, both as exercise and mind-body intervention. I'll skip this. This is going to be the future of autoimmune disease treatment. There is already, we use biologicals, we use nutritional interventions for celiac disease and synthetic drugs. But there's a lot of work going on fecal transplantation, fasting, cellular therapy, tapping the T regulatory cells, and it's not only drugs. If you see, it's not only drugs. There's so many strategies are being in the pipeline. So next 10 decade or so, we may have a different outlook of treatment of autoimmune rheumatic diseases. With this, I thank all the audience for patient hearing, and also I thank my mentor, Professor A. N. Chandrasekharan, and the lecturers who were there with him, Dr. Rajendran, Dr. Porkodi, Dr. V. Krishnamurthy, and Ramakrishnan, and also my co-trainees, Dr. Arunachalam, Dr. Venugopal, Dr. Rajshekhar. Together we all learned rheumatology, and I thank all of them. And I thank my parents, my family, and my beautiful wife. She is a dietitian, so she was the reason behind my interest in nutrition, and my extended family of my department. You can see Ramesh here, and my registrars, and my colleagues, and my larger extended family of Karnataka Rheumatology Association. My sincere thanks to all of them. And lastly, my thanks to my patient teachers. My interest in this area, non-autoimmune, not immunological technique, came from patients. They tried many things. Many of them improved. I don't discourage them. I say that you do whatever you want, I'll continue to follow you up. That has helped me. They come back and told me that they got better. And this is one of my patients, a young boy who had severe atopic dermatitis. He has stunted growth. He has been on constantly 24 hours of using steroid creams, etc. And we changed his diet. Within a couple of weeks, it did improve. And as the diet progressed, he improved significant enough so that he started introducing many of the food we was not tolerated to. But ultimately, when he was almost 80% improved, still struggling with few eczematic episodes, he went to a church. He is from Christian community, and they organized, grandparents organized a mass prayer for him. After the mass prayer, he was given the food he was allergic to, and that fellow tolerated it from that day onwards. I am still I'm following him for the last 1.5 years. He is tolerating all the food, and he has no eczema in his hand. So there are many ways to getting better, and autoimmune rheumatic therapy which we provide is one of the way. Thank you very much for patient hearing.
Thank you, Dharmanand, for the wonderful presidential oration, which I think is lateral thinking.